Thank you, Madam Chair, and thanks for having me here. If you'd like, I'll get started while there are several individuals that are joining me. And before I do get started, I just wanted to take a moment and thank Madam Chair and her very capable staff in helping me. Last time when we heard this bill, I committed my office and myself to working with your staff and your office and some of the other members' offices to ensure that we get to a point where everyone feels comfortable with this bill. And I think we have that now. So I look forward to continuing this work as well because it's an ongoing progress. Existing law mandates coverage of all prescribed evidence-based behavioral health treatments. However, existing law does not define what is evidence-based. As amended last week, AB 796 corrects this by directing the Board of Psychology to develop a list of evidence-based treatment modalities for purposes of insurance coverage. Additionally, the bill extends the sunset date on the insurance mandate to January 1st of 2012. Bless you. This bill recognizes that there is no one-size-fits-all treatment for an individual diagnosed with autism. Every child on the spectrum presents differently, and they respond to treatment differently. Existing law makes it difficult for families to obtain coverage for the prescribed treatments their children need and which they are entitled to under the law. In some cases, parents do challenge via the IMR process, the independent medical review process, and are successful in receiving the services needed. However, this takes time and effort, and many parents simply do not have the time or the capability to do so. My intent is not to limit treatment coverage or access to the IMR process or add any unnecessary steps to families receiving treatment. Rather, the goal of this bill is to ensure patients with autism receive the treatment they need and that the service is covered by their health plan and insurer. With that, I want to take a moment and introduce three witnesses that have joined me. Jim Lantry with DIR Floor Time Coalition, Dr. Janine Biesman from the San Fernando Valley, and Dina Ruiz, a parent from Diamond Bar.
Move the bill.
We have a motion and a second. In support.
Thank you, Madam Chair. Jim Lantry with the DIR Floor Time Coalition of California. When we wrote Senate Bill 946, the autism community was united that this was an opportunity to allow parents to get the treatment covered that they needed with no cost to the state. Unfortunately, what has happened is that many insurance companies have only looked at ABA as the covered treatment modality. There are many others that are based in evidence-based that are very valuable for children. As the Assemblyman mentioned, no one size fits all. Children are different. As you'll hear today, twins can actually be very different in the way that they respond to treatment. It is essential that we have these other treatments available. A parent that has with a child with autism and has to go through the IMR process is severely handicapped. It's not like those of us here that are skilled in government and skilled in the way of bureaucracy. They're not. And they've got the problem of having a child with autism. They shouldn't have to go through IMR if the other treatments are available. This bill would make it easier for parents who want to say, I want the treatment that my doctor prescribed. I want a treatment that will help my child. The insurance companies will have less grounds to say this is not evidence-based if the Board of Psychology says it is. It doesn't mean that treatments that aren't on the list won't be covered, because you can still go through IMR for those, but for those treatments that are on the list, it will certainly help save a parent the pain, the expense of going through that. And the other thing is that children with autism don't have that time to wait for that treatment. Treatment delayed is treatment denied. A child growing up is forming synapses and neurons and things like that every day. And it's incredibly important to make sure that they get the treatment that they need as soon as they can get it in order to reach their full potential. And with that, I ask the committee to support the bill.
Thank you very much. Next speaker in support.
Good morning, Madam Chair and committee members. I'm here today to share a story with you of two little boys, Stevie and Tommy. They are twins. They are 9 years old. They are my sons. They have autism. At the age of 3.5, both received the dreaded diagnosis. I must be honest, at the time, my husband and I were overwhelmed and in denial. We had no clue, no clear plan as to what we were going to do. We just knew that the boys needed help. So we started ABA therapy per the recommendation of our local regional center and their pediatrician. From the onset, it was clear that Stevie, who was at the time nonverbal and aggressive, responded very well to the highly structured, highly repetitive, adult-directed, reward-centered intervention. I am proud to report today that Stevie is a third-grade student, mainstreamed alongside his typical peers. The 4 years of ABA definitely contributed to his decreasing challenging behaviors, increasing his reasoning skills, improved his communication, and taught him the self-help and play skills he lacked. Now, I would like to tell you about my son, Tommy. He is the reason why I'm here today. Tommy, unfortunately, didn't have that same experience. His ABA sessions involved high levels of anxiety, tantrums, crying, and very slow progress. After 4 years, I was concerned with his emotional and functional development. We decided he had had enough, and I wanted to explore other treatment options. I contacted my service coordinator at the regional center, and she told me about floor time and that my insurance would be the funding source. This wasn't the case. My insurance company, along with 2 out of 3 doctors involved in an independent medical review, denied Tommy floor time based on the following, and I quote, ABA is an established treatment procedure for children with autism, and it is their intention to provide evidence-based treatment for autism. Floor time is not evidence-based. The insurance company reassured me that their goal was to provide the best possible and a compassionate approach. Nothing is farther from the truth. A compassionate approach would be to view Tommy as an individual and provide him with a comprehensive intervention plan such as floor time. Given the diversity of the spectrum, the unique strengths and challenges each individual faces, it is unreasonable to believe that the insurance companies only acknowledge ABA behavior intervention as the only therapy they will fund. The San Gabriel Pomona Regional Center finally agreed to fund the floor time after the IMR's final denial. Since starting floor time in May, he has made excellent progress. Floor time is respectful of his personality, very conscious of his many sensory needs, and is building on his strengths rather than trying to change his symptoms. Floor time helps Tommy to feel understood and encouraged, which fosters better behavior from him. He is able to communicate better, he is less anxious, and a much happier little boy. I believe that floor time is so important to Tommy. He no longer receives ABA at school. His behavior support plan and his one-on-one support are provided by our in-home floor time company, and our local school district agrees. Everything about autism is complicated, and now we know that no single therapy works for every child. Please, I ask you to hold the insurance companies accountable to fund floor time on behalf of all the children out there like Tommy who do not benefit from ABA. It is the right of every autistic child to have an effective intervention plan that will enhance quality of life. Thank you.
Thank you very much. Also in support?
Yes. Good morning, Madam Chair and committee members. Thank you so much for your time. I'm Janine Weisman. I'm a neuropsychologist. I've been in the field for several years. I have a strong subspecialty in the area of autism and neurodevelopmental disorders. And I do believe there are just a couple of main points to impart. One is that autism is indeed a very complex disorder, and as such requires individualized treatment options to best address the needs of the person and the family system. Without this, we'll see that there will be intervention options that will be costly and time-consuming and not effective if those individual differences are not taken into account. We do know that there is a compelling, strong evidence base for developmental approaches, and those should indeed be offered as a treatment option for families. And we also very much need to consider the true definition of evidence-based practice, which does look at the most updated research, and the law, of course, should be flexible enough to move with that research and to move with an understanding of advancing neuroscience and the impact of these individualized approaches. But evidence-based practice also takes into account clinical judgment. So a treatment team and a practitioner evaluating a child in a family system and suggesting this is the best path based on what I'm seeing. And then, of course, you can't ignore family values and family cultures as part of this process. All three components of that definition converge to really provide a family true informed consent. And this is what we need in advancing the treatment of autism. I also come at this with a lens of a parent. I do have a 12-year-old daughter who has autism, and we were offered ABA through our regional center very generously 20 hours a week, to which I knew this would not be the appropriate and right approach for her. So instead, I opted for 1 to 2 hours of developmentally relationship-based therapy with a parent coaching component, and she's doing swimmingly well in general education and indistinguishable from her peers, and it couldn't have worked out better, and I'm just grateful that I had the opportunity and the knowledge to advocate for my right for choice for her. Thank you.
Thank you very much. Others in support, if you want to come forward to the microphone and state your name and organization and your support position. Thank you.
Thank you, Madam Chair and members. Rick Rollins. I'm here wearing 4 hats today in support of the bill with the ABC Schools, which is an ABA provider here in Sacramento and also serves children throughout California with autism. The Autism Business Association, which is a group of roughly 12 organization of ABA providers in Southern California, Northern California, and also ARCA, the Association of Regional Center Agencies. And I'm also a parent of a child who's benefited from early intervention services. Russell was 9 years old when he graced the cover of Newsweek magazine. He's now 25 years old, and he continues to receive intervention services for his autism. This bill essentially has 2 parts, as you're aware. One, to extend the sunset for SB 946, the landmark legislation requiring health plans to provide services to children with autism, and also allows the Board of Psychology to start reviewing other modalities. I was very actively involved in the development of SB 946, and it was the intent of SB 946 from its inception that it be permanent after the initial sunset, and also that there are other modalities that will be considered under the umbrella of SB 946. So I'm here in support of the bill as a parent and the other 3 organizations. We look forward to working with the author on the bill moving forward. We would encourage that rather than having a 5-year sunset on the bill, that the sunset be removed altogether. When autism is sunsetted, we can sunset this legislation. Thank you.
Thank you very much. Others in support?
Good morning, everyone. My name is Fred Baldy. I am from Behavioral Intervention Association. That's the name of my company, our company, I should say. Why am I here? I'm here in support.
Thank you.
But let's talk a little bit of a bigger picture here.
Well, we're kind of wrapped up our testimony time, and we just need your support position.
Oh, that was all? I mean, I had to wait till the end to say I support this? Please. Is that true?
Well,
is that Barclay's rules or whatever they use?
Why don't you take 30 seconds and tell us why you're in support?
Well, I'm in support. We've been serving children since 1988 with children with autism based on Lovas ABA services. Lovas himself did a study in 87, and he started with 20 kids. 20 kids got whatever the community was offering at the time. This is back in the late 70s, early 80s. 10 of the other kids he did a 40-hour-a-week program with. Who did that 40-hour-a-week program? He had undergrads working with these kids. He had his graduate students running as managers. And then to oversight these programs, he used postdocs and himself. This is a landmark study from UCLA. So ABA has been here quite some time, and we've been providing services, wonderfully qualified services to the state of California for that long. And that's why I'm here. And I'm here because I think this could become the beginnings of a serious talk about cost containment. And I'll leave it at that because I understand you guys need to move forward. Thank you very much for your time.
Thank you. Anyone in opposition? I invite you to come to the table. Welcome.
Thank you. Melissa Cortez-Roth here on behalf of Autism Speaks. And we don't have a formal opposed position. We're still working through that process. But I did want to take the time to register their concerns. Autism Speaks is one of the nation's largest autism advocacy groups. And, you know, we do share the concerns and the goal that the author and the sponsors have. We want to see as many children covered with the appropriate therapies as possible. We were a co-sponsor of that original legislation, SB 946, and it's our belief that those other modalities, all evidence-based treatments, are currently covered. And I do want to thank the staff for recommending that change in the analysis, because as drafted, it appears to suggest that evidence-based treatments are not currently covered, and that list would be for the purposes of developing coverage. So we do want to thank the author and the staff for recognizing that. We do have additional concerns with the bill, and there was some discussion about the independent medical review process, and that's actually where our concern lies. I understand that the sponsors of this bill believe that this would prevent these cases from going to IMR, but it's our understanding that the issue that's sending these cases to IMR oftentimes relates more to who the provider is and how these codes are being billed. And we don't believe this bill resolves that issue. We actually think it will create more issues with the independent medical review process. Right now, if there is a challenge, something goes to independent medical review. If it's challenged based on medical necessity, or if a therapy is considered investigational or experimental. And our fear is that if a specific modality is not on this list, and we don't know how often this will be updated or revised, then that will weigh into the factors at independent medical review as to whether or not something is medically necessary, investigational, or experimental. And that's a huge concern for the autism community, because right now, although we wish they didn't have to go through this process, overwhelmingly, when something is challenged in IMR, I think the Health Committee analysis cited at 93% of these cases when they go to IMR are found in the consumer's favor. If something is not on this list, does that change those numbers? Does that push that pendulum the other way? That is a big concern of ours. We also question the appropriateness of having the Board of Psychology determine what is an evidence-based therapy when there are a whole host of other providers who do this treatment. Under current law, a qualified autism service provider is a certified behavior analyst, a physician or surgeon, a physical therapist, an occupational therapist, a psychologist, a marriage and family therapist, an educational psychologist, and a clinical audiologist. So now we have the board of just one of those entities determining what is evidence-based. Should the Board of Psychology be determining what is an evidence-based therapy for a marriage and family therapist to provide, for an occupational therapist to provide? We are concerned that that could cause issues down the road. Again, we do share the concerns of the author. We would like to see all treatments, all evidence-based therapies provide coverage without having to go through the painstaking processes of being challenged through IMR. But the underlying issue of who the provider is, or whether or not it's billing coded appropriately, is not addressed in this bill. we look forward to working with the author should this bill move forward. Again, we share those concerns, but in its current form, we do have significant concerns.
Thank you. Anyone else who would like to speak in opposition to the bill? Seeing none, do we have any questions from the committee? Yes, Ms. Baker.
Thank you. First, I just would like to thank the parent witnesses for sharing your experience. The story of Stevie and Tommy as a parent of twins and knowing how different they are, I appreciated that. I also want to particularly thank the author of this bill. In its original form, it was not something I could support, but that you have really worked on a creative, good solution. And I am looking forward to voting for the bill. And I think it was a good way to go in the work that you've done in the last several months. I did just want to ask if you wanted to touch on two issues that were just raised in opposition or one of your witnesses. One is how often will the list potentially be updated so that if there are continued changes and new science or other points, how often might that be addressed, or what would be the best time frame? And the second is the Board of Psychology deciding what is evidence-based. I believe the bill in its current form is good, but I welcome your thoughts on those 2 points.
Sure. Thank you very much. Part of the reason why we were thinking of not putting anything into statute was because this is such a developing arena and that there's going to be changes on an ongoing basis. And so there was no need to verbatim put in any of the treatments into statute or code, and instead allow the experts on the Board of Psychology to, based on the research and based on the advances of treatment that take place on a daily basis, to come up. But we also did not cite a specific timeline of when they would do that. Going forward, maybe that's something that we can work around and see if it's feasible to do in the bill. I'd be open to that very much. And the second point, Jim, if you'd like to respond.
I'm sorry, the second point again.
Goes to the issue of concern about just the Board of Psychology being the only ones to decide what is and isn't evidence-based treatment modality.
If you look at the definition of evidence-based practice, as Dr. Beisman was suggesting, is actually three things. It's whether it's supported by research, using clinical judgment, and the cultural and family values of the patient. All we're asking the Board of Psychology to do is to determine if that first leg of that three-legged stool is there, if there's research to support it. And I believe the Board of Psychology is in a position to be able to look at the research, whether it's something for marriage and family counselors or licensed clinical social workers or whatever, and say, is there research to support this particular treatment modality? It is up to the individual practitioner underneath that evidence-based practice definition I just gave to determine whether or not that particular treatment is right for that particular child. And so whether that person is a marriage and family counselor or whether it's an occupational therapist or whatever, they're the ones that are going to make the decision. And all the Board of Psychology is going to do is determine whether or not there's evidence to support it and research to support it. And I believe that they are in a position to be able to do that. However, that being said, we are more than open to the idea as this bill moves forward, and hopefully it will move forward today, to working with Autism Speaks and the other various kinds of providers that are out there to make sure that we have the right body to do that analysis. But at this point, again, all they're doing is making sure that there's research out there to support it and that it meets that first test.
Thank you. Any other questions? Would you like to close?
I respectfully ask for an aye vote.
Thank you. This is a due pass to health. Take the roll.
Bonilla.
Aye.
Bonilla, aye. Jones.
Aye.
Jones, aye. Baker.
Aye.
Baker, aye. Bloom. Aye. Bloom, aye. Campos. Aye. Campos, aye. Chang. Aye. Chang, aye. Dodd. Eggman. Gatto. Aye. Gatto, aye. Holden. Aye. Holden, aye. Mullen. Ting. Aye. Ting, aye. Wilk.
Not voting.
Wilk, not voting. Wood. Aye. Wood, aye.
That's 10-0. The bill's out. We're also, thank you so much.
Thank you.
Thank you.
Yes. See you in health. We'll now vote on the consent calendar. Do I have a motion for the consent? Second. Okay, we have several motions. And we'll take, this is on the consent calendar, AB 923, Stein North, AB 1084, Bonilla, and AB 1174, Bonilla.
Bonilla.
Aye.
Bonilla, aye. Jones.
Aye.
Jones, aye. Baker. Aye. Baker, aye. Bloom. Aye. Bloom, aye. Campos. Campos, aye. Chang. Aye. Chang, aye. Dodd. Eggman. Gatto. Aye. Gatto, aye. Holden. Holden, aye. Mullen. Ting. Aye. Ting, aye. Wilk. Aye. Wilk, aye. Wood. Aye. Wood, aye.
11 to 0. The consent calendar is passed. I'd invite Assemblymember Lowe to come forward as you are signed in to present 1386.
Thank you very much, Madam Chair and members. I'd like to start off by thanking the committee and staff for working with me on this bill, and I would like to accept all the recommended amendments noted in the analysis. Assembly Bill 1386 will voluntarily allow businesses and organizations and other entities to obtain a prescription and to stock epinephrine auto-injectors for use in an emergency. Allergies, as you know, are a large part of the growing public health problem. And today, an estimated 1 out of 13 children and 1 out of 20 adults in the United States has a food allergy, many of us probably here today, and in considerably a higher number than estimates only a few years ago. Failure to administer epinephrine early in the course of a treatment has been repeatedly implicated in fatalities. Currently, 47 states have laws to allow or mandate schools to stock auto-injectors, but schools are not the only place where children come into contact with these allergens. And it is of note that 19 other states have a similar law in place. This bill would provide access to auto-injectors and make them more readily available in places where individuals can access them, and also provides liability protection to businesses, organizations, and entities that obtain these auto-injectors. With me here today, speaking in support, Devin Anderson, representing the Red Cross, and Bruce Lott with Mylan. Thank you very much.
Thank you. In support. Thank you. Please introduce yourself. Thank you.
Thank you. My name is Bruce Lott, and I'm the Vice President of State Government Relations for Mylan. My apologies about the sore throat. I'll promise to be brief and not make this too painful for you. Thank you for the opportunity to speak today. Mylan is a leading manufacturer of generic and specialty medications, and one of our subsidiaries markets one of several epinephrine auto-injectors that are currently available in the United States. Today, an estimated 1 out of 13 children and 1 out of 20 adults have food allergies. But food allergies are not the only reaction that can cause anaphylaxis. Insect stings, medicines, and latex are among them as well. Over the past few years, thank you. Over the past few years, there have been several high-profile anaphylaxis-related tragedies around the country, in schools and outside of schools. Deaths in Illinois in 2011, Georgia and Virginia in 2012, California, Texas, and New York in 2013, and Minnesota in 2014, resulted in significant attention to the issue and much discussion on how to address it. Anaphylaxis results in approximately 90,000 emergency room visits each year in the U.S. and 1,500 deaths. As mentioned, California is one of 47 states that allow schools to stock epinephrine auto-injectors. And to our knowledge, at least 62,000 schools nationwide are currently stocking these because my company provides them free of charge to schools. We know that at least 9,500 schools here in California currently stock epinephrine auto-injectors. AB 1386 will build upon the school access law and the lay rescuer laws and will expand access to critical medication to authorized entities including daycare, colleges, summer and day camps, restaurants, and others. As mentioned, 19 states have already passed similar legislation. The most recent signed into law was yesterday in New Jersey. We look forward to working with the advocates and other interested parties as you consider this important legislation. I'm happy to take any questions if you have them for me.
Thank you. In support?
Devin Anderson here today on behalf of the American Red Cross. Just here to lend our support and, of course, let you all know that this fits into with the Red Cross's overarching mission of emergency preparedness. Thank you.
Thank you. Anyone else in support that would like to speak? Anyone in opposition to the bill? Seeing none, any questions from committee members?
Just real quick, Madam Chair.
Yes, Mr. Speaker.
Thank you, Mr. Lowe, for bringing this bill. I think it's terrific, not just as a parent who had a child with food allergies, or has a child who used to have food allergies and had to carry the EpiPen, but also, as, many people in our communities volunteer in youth organizations that are not in a school setting and know that there's a child there that may have forgotten their EpiPen, and if something were to happen, there's not something we can help them with. And it's like having the defibrillators, just knowing that that's something to ask for. And I would welcome an opportunity to co-author this with you. I think it's a great bill, and thank you for bringing it.
Thank you very much.
I will just make a quick comment and let you respond in your close. In the analysis on page 7, it does point out that SB 669 by Senator Huff established a training program for people who wanted to be able to receive an EpiPen. In these organizations, they have to have one person who is trained in order to get the EpiPen. However, we really don't have resolved the issue of the fact that that trained person may not be there when the emergency arrives. I don't see that as an insurmountable problem. I support the bill. I think we need to figure out going forward how we uphold the bill, the Senate bill that we supported and passed, along with this idea that basically untrained people now will be, which I think is probably okay. There's not a great deal of risk to using the EpiPen. But would you like to address that in your close?
Sure. Well, thank you very much, members, and for your comments. Assemblyman Baker. Certainly, this, as you know, this is double referred also to Judiciary, and this issue and clarification, I'm happy to work with you to clarify and work on these issues. I do think it's important that we talk about who is liable and talk about the Good Samaritan law too. That's also equally important, because I know there are many individuals who want to provide the level of service to individuals, and they want to be held liable. And so certainly we'll be able to address many of these issues in continuing to work on the bill.
Thank you.
And I respectfully ask for your vote.
Great. Did we have a motion yet? Okay. Ms. Eggman moves, and then somebody seconded. Multiple people seconded. All right. This is a due pass to Judiciary. Thank you. As amended. Thanks for taking the amendments.
Bonilla.
Aye.
Bonilla, aye. Jones.
Aye.
Jones, aye. Baker.
Aye.
Baker, aye. Bloom.
Aye.
Bloom, aye. Campos. Campos, aye. Chang.
Aye.
Chang, aye. Dodd. Dodd, aye. Eggman. Eggman, aye. Gatto. Gatto, aye. Holden. Holden, aye. Mullen. Ting. Ting, aye. Wilk.
Yes.
Wilk, aye. Wood. Wood, aye.
13-0.
Thank you very
Highest
much,
number
members.
today. Good job. Passed.